Hello, and welcome to this webinar presented by IHPA on Hospital Costing Insights. My name is Julia Hume, the Executive Director, Data Analytics at IHPA.
And I'm Iman Mehdi, Director of Hospital Costing at IHPA.
I would like to respect and acknowledge the traditional owners of the many countries throughout Australia and recognise their continuing connection to land, sky, waters and culture. We pay our respect to elders today and those who walk in spirit. In today's webinar, we will address what the National Hospital Cost Data Collection is and the steps which IHPA undertake to understand and improve the data quality of the collection on an annual basis. We'll touch on and introduce the Australian Hospital Patient Costing Standards and also have some discussion on what the work plan for the hospital costing area is for the 2022 year. Costing is one of the foundations of activity-based funding. At IHPA, we are responsible for the National Hospital Cost Data Collection, which is it's essential to understand the costs involved in the provision of hospital services to a patient and assign costs based on resource consumption. So we collect the NHCDC, the National Hospital Cost Data Collection, annually, and we work with jurisdictions and hospitals in the development of the Australian Hospital Patient Costing Standards. We use the information to develop classification systems and as the basis of our pricing model. The other foundations of activity-based funding are collecting activity data, which describe the episode or service which is being provided to a patient at a hospital. IHPA manage the classification systems across Australia, and also we set the national efficient price on an annual basis.
National Hospital Cost Data Collection, or NHCDC. What is the NHCDC? The National Hospital Cost Data Collection is a collection of patient-level cost data that IHPA undertakes annually. The NHCDC includes type of services provided to hospital patients in a financial year, normally from 1st of July until 30th of June. And it also includes the cost of providing these services. The NHCDC has been collected over the last 20 years. The collection captures costs for patients receiving care types for admitted acute, subacute and non-acute, emergency department, mental health and non-admitted. How is the NHCDC collected? The NHCDC is collected from hospital provided to jurisdictions, and then jurisdictions provided to Commonwealth, which is IHPA, currently IHPA. The costs are collected by episode at the cost center and line item level. When IHPA receives the data from jurisdiction, it matches the cost data with the activity-based funding activity data that IHPA also collects on a quarterly basis. The data that jurisdictions submit will be in accordance with the Australian Hospital Patient Costing Standards, and also will be in accordance with the data request specification that IHPA provides to jurisdictions before the collection starts. The jurisdictions submit their data through an IHPA data portal. It's a submission portal where the jurisdictions upload the data and gets automatically validated and checked to ensure that the data is correct and in accordance with the DRS. Once IHPA receives the data from all jurisdictions, as I said earlier, it matches the cost data with the activity based funding activity data, and once this is done, IHPA undertakes an ETL process, which is extract, transfer, load, transform, load, and this is a grouping the cost center and line item into a cost bucket matrix. The cost bucket matrix include costs associated in delivering these services, such as pathology, imaging, and so on. And this is just a screenshot of the cost bucket, and you can see all the line items, salary and wages, nursing across the top, and other line items as well. And then on the left-hand side as well, we have the cost center group, and that's how the cost data is grouped. That's what the cost data is grouped into. What is the NHCDC data is used for? The primary use of the NHCDC data is the development of the NEP, the National Efficient Price, but also the NHCDC data is used for benchmarking, for research, and also for classification development. And given that the collection has been over the last 20 years, so the data is a high quality, it's more reliable and more comparable. The NHCDC outputs. After each collection or annually, IHPA publish cost reports, the NHCDC report on its website, and also publish the appendix tables, where the appendix tables is a detailed table summarizing the changes in the data over the 3 years for all streams, that is acute, subacute, emergency departments, and all the other streams as well. And also we publish an infographic, which is an easy overview of the cost data in more fun picture way.
To promote consistency and allow comparisons between cost data sets, IHPA with jurisdictions has developed the Australian Hospital Patient Costing Standards. In 2017, the AHPCS version 4 were published. Throughout 2016 and 2017, the standards were developed, and it was a significant change to what had been previously used in version 3 of the standards. And really the significant change was in how the documents were presented rather than the content of the documents. So the AHPCS have been structured into a set of 3 related documents. There's standards, business rules, and costing guidelines. And each of these documents is tailored to a different audience. And they can be used as a set or standalone. They can be used to understand the overarching principles or applying those principles in the hospital setting. The standards themselves are the overarching principles which are used to support and inform each step in the process of patient level and product costing. The standards are designed to inform the recommended approach to the costing process, and they're not meant to be static. They are principles to be applied as appropriate within each hospital setting. And we understand that each hospital, LHD, jurisdiction vary quite a bit, and the information available to complete the costing process is also varies by site. The structure of the standards is intended to closely align with the costing process, and the standards are evolving guidelines that will continue to be updated and improved upon as the costing process developed and as IHPA works with jurisdictions. The business rules provide practical guidance on how each standard can be translated into action. They have been written from a costing practitioner, that's the person in a hospital or local health district doing the costing, from the costing practitioner's perspective, and take into account the practical and operational constraints that they might be facing within their organisation. The business rules provide information, requirements, and definitions to assist with the costing of some more complex services. And the business rules follow the costing process from the general ledger through to the final reconciliation of audited accounts, through feeder systems, information sources used in the costing process, an example of that could be theatre times, would be a IT system, an information system which is used to inform the costing process. And thirdly, we have the costing guidelines, which have been developed to guide the costing practitioner on how to cost various services within their hospital. The costing guidelines demonstrate the practical steps, and they are steps in the guidelines, to be undertaken when applying business rules to each stage of the costing process. And it's really important that the costing guidelines are about ensuring that the best possible evidence is used and collated when applying costs to individual patients. So this is the 6 stages of the costing process. Stage 1 is about identifying relevant expenses, and these will predominantly be within the hospital's general ledger. They could be from external to the general ledger and still relate to the delivery of patient care. And so it's important to identify those costs as well and incorporate those into the costing process. Stage 2 is creating the cost ledger, so pulling both the expenses from within the general ledger of the site which is doing the costing, as well as costs from external to the general ledger into the costing system to create the cost ledger. And that's making sure, mapping cost centres and line items so that there's consistency within the costing process. Stage 3 is about creating the final cost centres and within that costing system. Stage 4 is about identifying products, and these could be an interim product, which is part of a patient's care, or resource utilisation. It could be a bed day, it could be a number of pathology tests, it could be time in theatre, or it could be the end product or the end class, which is assigned at the end of an admitted episode of care or at the end of an emergency department presentation, which describes the classification, which describes the overall interaction with the hospital service. Stage 5 is getting the costs from the cost centres within the system and linking those to the products, whether it be the cost associated with a particular pathology test, or and then also grouped up into the episode level. Stage 6 is really quite important. They're all important, but stage 6 is going back and reviewing and reconciling for each step along the costing process to ensure that the dollars and activity at the start of that were identified at the start of the costing process have been accounted for at the end of the costing process.
The quality assurance reports. The quality assurance reports are provided to jurisdictions after initial submissions. The quality assurance reports are designed to identify any unexplained or anticipated outcomes in the data. It also shows the change between years from previous round to the current rounds, and increasing costs or decreasing cost, and also the quality assurance reports include average cost between rounds, cost bucket and line items, and also includes cost reconciliation table and cost weight table. And here the snapshots of the reports that we provide to jurisdictions. The jurisdiction review those reports, and then based on this report, they can make the decision on the data if they are happy with the report and what the data in the report reflects the data submission. Then they confirm to IHPA the data to the NHCDC is final. If there is any issues with the reports, or if the data is not correct, or for any reason they're not happy with the reports and the data that's reflected in there, then they will advise IHPA to resubmit the data. And when they resubmit, and then the process starts again from the beginning. The data quality statements. The data quality statements are signed documents by jurisdictions, and data quality statements explain any variation in the preparation of jurisdictions' NHCDC submission. The jurisdictions or the data quality statements include confirmation from jurisdictions to their adherence to the standards, which is Australian Hospital Patient Costing Standards, and also if there's any changes to the system used to prepare the NHCDC, any opening or closing of a hospital, or any issue with the data that they face during that financial year. Another data quality or assurance that IHPA take on an annual basis is the independent financial review. The independent financial review is an annual validation process, and this is to verify that the hospital submissions include appropriate costs and activities, and also confirming that the NHCDC data is fit for purpose for an EP development, which is the National Efficient Price. The independent financial review also assesses the accuracy of and completeness of the NHCDC, the application of Australian Hospital Patient Costing Standards, and also the data flow at each stage of collection and process, that it is correct and reconciled. And here's a snapshot of what's included in the report. The review ensures that the data flow from hospital to jurisdictions is reconciled, and from jurisdictions to IHPA as well as reconciled. Any adjustment, inclusion or exclusion of cost at any stage of this process, it needs to be verified, and also if there's any variances between what jurisdictions submit and what IHPA receive, and also this should be explained. For example, at the top here, where you can see that there is some adjustment that IHPA made to the admitted ED reallocation, and this is explained in the report as well.
Now that we've taken a look at the NHCDC collection itself, the Australian Hospital Patient Costing Standards, and some of the processes that IHPA works with jurisdictions on as we attempt to understand the data and understand how the standards have been applied, and understand the appropriateness for using the data. We'd just like to take a couple of minutes to talk about the future work program. And just to be clear, we're just talking about within the costing section here at IHPA, not broader than that. So in late 2019, IHPA developed a relationship with University of Technology in Sydney, and we requested that they undertake a piece of research, a study, to understand how the purpose, design and use of costing data in Australia. We know it's a really valuable data set. We also believe and think from feedback that we get from jurisdictions, from clinicians, that it's not fully used or used to its full potential within the hospital setting. So we engaged UTS, and they spent a lot of time, as did many jurisdiction and hospital representatives, to understand how the NHCDC data set And the costing data before it comes to IHPA and becomes the National Hospital Cost Data Collection. We know that it exists in hospitals before it's called the NHCDC, but to try and understand how this costing data is being used. That report had a number of recommendations in it and is available on IHPA's website. And these recommendations will be considered by IHPA with our stakeholders through our advisory committees to try and inform the development of a work program, with the aim of that work program being to improve the use and the quality of that data collection. So the first of those recommendations was around improving consistency in the application of the costing standards, and also to increase the transparency of the costing methodologies at the hospital level, and also to increase the timeliness of NHCDC submission. Well, not necessarily submission, but the timeliness of reporting and making that data available. At the moment, IHPA collects data on an annual basis, and at the end of the financial year, which is June 30, we know that it's not a simple process for jurisdictions and hospitals to prepare cost data. However, we don't receive it at IHPA until perhaps February of the following year, so that's 8 months after the end of the financial year, and generally it takes another 2 or 3 months before we're able to finalise that data collection, and then another 2 or 3 months before we are in a position to prepare any reports or benchmarking data on that collection. So it can almost be 2 years since the end of the financial year to when the data is available. And that is also then linked to the granularity and scope of data available in the National Benchmarking Portal. Currently, the benchmarking portal is available through jurisdictions, and IHPA are looking at options to increase the availability of some of that information. Another recommendation was around engaging with health professional bodies and peak bodies, and to promote and educate on cost data collection on the NHCDC and ways that it can be used at the hospital level. And also for IHPA to work with jurisdictions to promote patient level costing. And this is a figure from the report which we received from the UTS. It's available on our website, and it's a 5-year program of options of how we might implement some of those recommendations. IHPA has plans to talk to our stakeholders and our committee members to agree on an approach to implementing this. Finally, we have another number of areas of work which IHPA will continue to engage with stakeholders on over the next 12 months. The first being the Australian Hospital Patient Costing Standards. We will continue to identify areas which need clarification or aren't relevant for the current costing process. We'll continue to work with the private hospital sector to improve the quality and consistency and expand the scope of the private hospital National Hospital Cost Data Collection. IHPA produce a report on that data collection on an annual basis. We're completing the independent financial review for the 2019-20 year at the moment, and that review will have, we expect there to be a number of recommendations around costing and costing processes that we can also implement in the coming year. We will be receiving the NHCDC for the 2020-21 year in early 2022, and we expect that there'll be significant variation in that cost data caused by the COVID-19 pandemic, and so we'll continue to work with jurisdictions to try and really understand the impact of the COVID-19 pandemic on the costs associated with delivering patient care. And finally, IHPA has just recently commenced in November 2021 a residential aged care costing pilot study to inform some of the work which we've been asked to do in relation to developing pricing recommendations for residential aged care facilities.